Assalamu alaikum, everybody, and good afternoon. Happy to be here again. Sorry for having overdose of me. But again, it's glad to be here in Dar International Conference. And here. Yeah, thank you. So I'm here to cover a glimpse on cardiovascular protection across the cardiorenal metabolic condition using specific molecule, and I share Professor Farghali that breathing out and saying Jardians here without saying the scientific nomenclature. So what I'll be doing here in the coming 20 minutes is just to refresh our memory about the concept of the cardiorenal metabolic approach of diabetes, and then what's to be taken over afterwards. These are my disclosures. And just to remind you that diabetes, cardiovascular disease, and kidney disease are intermingled probably before we have the full clinical picture of diabetes. So that's why now the CRM, or the cardiorenal metabolic concept, is in daily basis on the rise in terms of the holistic approach in treating people with diabetes, not only glucocentric approach. Probably a patient from day one be either at high risk of having cardiorenal disease or already having an established cardiorenal disease. So a patient with an early phase of diabetes might be having an already concomitant cardiorenal jeopardy. So, and there is a strong intermingling between diabetes, cardiovascular disease, and type 2 diabetes. So probably somewhere around 40% of people with type 2 diabetes might have already established chronic kidney disease. 60% of people with CKD might have a cardiovascular disease, and this is the #1 killer in people with advanced chronic kidney disease, as you all know. 40% of people with heart failure might have a chronic kidney disease, and this is a cardiorenal syndrome. And around 30% of people with type 2 diabetes might have cardiovascular disease. Around 40% of people with heart failure might have a background of type 2 diabetes. So 20 to 40% of everything might lead to something else in terms of diabetes, cardiovascular disease, and renal disease, which gives a proper intermingling picture of cardiorenal metabolic jeopardy. That's why we need to tackle 3 of them from day one and forward. I always like to give such talks in clinical-based or case-based discussion. So sorry for the very basic case, but I need to build on that. So Mr. Ahmed is a 57 years old gentleman. He's a banker, a very newly diagnosed with type 2 diabetes. Blood pressure is not bad, BMI 34, and he just started lifestyle already for obesity. His HbA1c is 7.4, LDL is not bad, less than 100, and albumin creatinine ratio is 98 with normal eGFR. ACR has been repeated twice. Currently, he is not on any medications. So, fresh, newly diagnosed type 2 diabetes with HbA1c 7.4 and high-ish albumin creatinine ratio. So what's the final risk stratification for Mr. Ahmed? He's newly diagnosed type 2 diabetes, and this is, we know, plus what? Is it low risk of cardiovascular disease, high risk, very high risk, or established cardiovascular disease? Just allow me to take you to one of the risk stratification engines that we are adopting here in this part of the world, the Emirates Diabetes and Endocrine Society risk stratification engine. And I know this is a very busy slide. I'll just take you quickly through it, that if the patient is at young age with shorter duration of diabetes, with a little number of other cardiovascular risk factors or cardiorenal risk factors, he will be either at low or moderate risk of future cardiovascular disease. As this goes on, either the duration of diabetes or number of cardiovascular risk factors, the risk stratification goes higher and higher. A more senior person with whatever duration of diabetes and risk factors, again, takes him a step forward to high risk or very high risk. But if the patient is having already type 2 diabetes with an established cardiovascular disease or a target organ damage, regardless the duration, age, and other risk factors, he will be directly going to a very high-risk stratification category. And Mr. Ahmed now, he is a fresh, newly diagnosed type 2 diabetes, young in age, around 50 years, but he has microalbuminuria, or what's called the mild albuminuria. So this takes Mr. Ahmed straight away from day one into a very high risk of future cardiovascular disease. And now the diagnosis will be a newly diagnosed type 2 diabetes, which could have been treated as a fresh newly diagnosed diabetes and just give him metformin and get back to us after 4 to 5 months. But with a single added information, took Mr. Ahmed from newly diagnosed diabetes to a newly diagnosed at a very high risk of future cardiovascular disease, which dictates a different treatment plan. And I take you to the slide that probably you have seen a million times, but just to refresh our memories, this is the latest American Diabetes Association guidelines that now if the patient is at high risk of future cardiorenal disease or established disease, then the first line therapy should be a cardiorenal protective medication. Even the metformin that we used to see it here, that start with metformin and add on something from day one, it's no longer there. So if the patient is having either borderline glycemia or highish glycemia, so the first line therapy could be either combination of metformin plus cardioprotective medication, or even only a cardioprotective medication without metformin. So Mr. Ahmed lies perfectly here that he's having normal eGFR, but he's having proteinuria. If he's the same patient having heart failure or at high risk of heart failure, then again SGLT2 inhibitors should be one of the first liners. If the patient is having either established cardiovascular disease or a high risk of future cardiovascular, atherosclerotic cardiovascular disease, still the SGLT2 inhibitors should be the first liner, plus or minus GLP receptor agonist. And this is no different from the KDIGO guidelines, one of the most reputable nephrology guidelines in the world now. This is the latest guidelines. They stated that the initial step is always lifestyle modification, and it should not be only the initial, it should be starting here and continue with us until the end of the treatment paradigm. And the first line therapy is a dual combination of metformin and SGLT2 inhibitors. So this, Mr. Ahmed, even the HbA1c is not far from the target that we're looking for, and cardiorenal protective medication has to be on board based on different clinical guidelines or scientific guidelines. And this is the American Diabetes Association, and European Association of Study of Diabetes, two different guidelines, KDIGO guidelines, and the combination of KDIGO and ADA. They all recommended the first line therapy in any patient with whatever stage of CKD should be the SGLT2 inhibitors, but until certain eGFR, we'll come to that in a minute. And the evidence that we have now is pretty reassuring. Probably most of us remember just 2-3 years backwards where we used to say, do not initiate or continue SGLT2 inhibitors when eGFR falls below 60. And we were having a bit of breath out when we reached 45. And now we are comfortably saying that you can go down until eGFR of 20 and even beyond that, but this has to be in expert hands. So general indication now that if we want to reduce the kidney deterioration or prevent the kidney from having further deterioration, we can start and continue until eGFR of 20. Same for cardiovascular death and heart failure hospitalization reduction. Again, you can go up to eGFR of 20. Protection of atherosclerotic cardiovascular disease, eGFR of 30. And the glycemic control when only the eGFR is beyond 60. So more than 60, we expect a potent glycemic control from SGLT2 inhibitors, but the cardiorenal protection goes down until the eGFR of 20 and probably beyond that. And we are having fingers crossed for the data coming for dialysis patients as well. So the treatment plan for Mr. Ahmed would be straightforward, that this gentleman should be on metformin plus SGLT2 inhibitors from day one, even regardless the HbA1c at that point in time. And we should have a very low threshold of adding GLP receptor agonist at earliest, whenever it's still having the obesity, the uncontrolled A1C. So the combination of two cardioprotective medications should be on board as much as possible. Quickly, this case number 2. Same Mr. Ahmed, 57 years old, is having a longer standing type 2 diabetes and hypertension. Blood pressure is controlled, BMI is highish. He's having bilateral lower limb edema, controlled A1C, uncontrolled LDL. His echo showed an ejection fraction of 45%, and still we have a pending pro-PMP. Currently on sitagliptin, metformin, and perindopril. So, what's the current status? Should we wait for the pro-PMP or not? And the answer is not. Probably Dr. Hani will tell us more about that in a minute. But now that we have different segregations or categorization of heart failure, we have the heart failure with reduced ejection fraction, where the ejection fraction is less than 40%, and heart failure with preserved ejection fraction when the ejection fraction is more than 50%. And this is the area, the gray area in between, which is the moderate reduction of ejection fraction, anywhere between 40 and 50. These areas where we did not have any medication that did take any action before having SGLT2 inhibitors on board. So as of now, the only medication that takes care of this category of heart failure is, as of now, is the SGLT2 inhibitors. So the current state of this gentleman is having a controlled diabetes with mild reduced ejection fraction heart failure. We have a couple of data or studies conducted in heart failure in different SGLT2 inhibitors, and Empagliflozin or Jardiance had two studies, which is the focusing on heart failure with reduced ejection fraction and heart failure with preserved ejection fraction, and it was successful in both of them by reducing the cardiovascular death or hospitalization with heart failure by 25% in EMPEROR reduced study and 21% of the cardiovascular death and heart failure hospitalization in EMPEROR preserved study. And worth noting that the patients in this study were either on a background of diabetes or not. So even patients with no diabetes on the background will benefit from the SGLT2 inhibitors when there is risk of heart failure. And one of the important points that needs to be noted that the number needed to treat to protect 25% of those patients is only 19. Those figures, we were not used to see such figures a couple of years ago. We used to see 70 patients, 100 patients to save one life. But now, with the newer cardioprotective medications, we now starting seeing 19, 20 plus. And again, number needed to treat here in EMPEROR preserved were only 31 patients to prevent a cardiovascular death. Just worth mentioning that we had a discussion yesterday about the volume depletion in SGLT2 inhibitors, and the data from EMPEROR reduced the volume depletion in the active arm was 10.6% compared to 9.9% in the placebo arm. There was no statistically significant difference. Even in the EMPEROR preserved, there is a slight difference, but again, it was not statistically significant. So the main concern of volume depletion in the large mega trials was not a clinical concern. Again, a couple of scientific societies have suggested that SGLT2 inhibitors, whenever the patient is having any stage of heart failure, should be the first-line therapy, especially when the heart failure is reduced ejection fraction. And it's, again, foundation therapy for any patient who is at any stage of heart failure. So now the SGLT2 inhibitors have moved from just being a glucose-lowering agent to a foundation-based therapy for treating heart failure at different stages. And this is the recommendation from different international guidelines. And just to remind you that we are in DAR conference, I think I missed that. So my last slide is the safety of SGLT2 inhibitors in people fasting or watching fasting Ramadan. I highlighted some of these studies in my presentation yesterday, but these are all the studies conducted on SGLT2 inhibitor safety in Ramadan, all of them. This is a systematic review in a process of being published soon, and I summarized the table. It's way longer than this and busier than this, but I need you to focus, please, on eGFR changes, dehydration, and the complications. If we started with DKA and thrombosis, none of the studies showed any safety remarks from using SGLT2 inhibitors in those patients. And the patients were at different risk categorization across from mild risk to moderate to severe risk of having complications. So no decay at all, no thrombosis at all, no hospitalization at all, and that was another column. And the dehydration and fluid homeostasis abnormality was only encountered as clinically significant in Kratos study and never encountered again. And it's either not significant or not available. The data was, the p-value was not available in such studies. While the eGFR changes was significant in 2 studies, and that was also reversible in many other studies that followed the decline in eGFR afterwards. So out of all 12 studies that we have in hand now, the only safety concerns was encountered in Kratos study by dehydration, which could be modifiable and preventable, and the decline in eGFR and nothing else. And with that, dear colleagues and friends, please allow me to conclude that empagliflozin has shown a favorable effect on cardiovascular and kidney outcomes in large clinical trials in patients with or without type 2 diabetes. Empagliflozin could preserve kidney function and improve outcomes in patients with CKD with or without type 2 diabetes as well. Benefits were sustained at a lower eGFR of 20 and beyond. In CKD or cardiovascular disease with or without diabetes, SGLT2 is either a first-liner or co-first-liner therapy and less contraindicated. And in Ramadan, courtesy of DAR, that SGLT2 have shown a robust safety profile from various studies. And I'm happy to take any question. I'd like to thank you very much for your attention.